Educating and learning is a passion of mine, always has been. It was in my previous life as a teacher and is now with my work as a patient advocate in breast reconstruction. So for today's podcast, I want to start out with a quote from Socrates on learning. Education is the kindling of a flame, not the filling of a vessel. In this episode of the DiepCJourney podcast, I'm going to unveil an educational opportunity I recently had, and I came to learn about it through a friend of mine. She's a patient advocate friend. We have yet to meet, but we speak often. We share the same passion about educating on the topic of breast reconstruction. Luann Lawrenson Woods, she has a very robust Instagram account. She had one of my guests, on her Instagram live recently. She's really the one who kindled that flame on today's topic for me. I'm also happy to share that she just recently started her own podcast. So go over to Spotify and check it out. It's called Rewritten Me. As I said, I watched an IG Live with one of her guests, Dr. Joe Dusseldorp, who is one of my guests this morning. But wait, there's more. My other guest, like me, is from the US. His name is Dr. Minas Chrysopoulo. I'll address them today as Dr. Joe and Dr. C as we chat. What really piqued my interest was a term that Dr. C used on his LinkedIn account, and it was the term democratization. Today, we're going to talk about democratization as it pertains to surgery. Dr. Joe and Dr. C are two outstanding microsurgeons who joined each other cross-continental, real-time, in a surgical robotic assisted Diep Flap via the Proximie integrated learning system in surgery. And I think the capabilities to learn from each other holds great promise in surgical care and really beyond the world of breast reconstruction. Dr. Joe is an internationally trained microsurgeon who practices in Sydney, Australia. Dr. Minas Chrysopoulo is a world-class trained microsurgeon, current president of PRMA, Plastic Reconstructive Microsurgical Associates in San Antonio, Texas, and he's the founder and developer of the Breast Advocate app, a free shared decision-making app for those affected by breast cancer and considering breast surgery. So I'll have links in the show notes to all of their information and contact so that you can learn more. So gentlemen, welcome back to the podcast. Are you both like going for a record on the DiepCJourney podcast?
Just love it here.
Feels like it, yeah.
Okay, well, I'm glad to hear that. So how about we start out? Now, you guys are both, one, Dr. Joe, you're in Sydney, and Dr. C, you are in the US. But if you could each tell us a little bit about your background, and I'm going to let you do that today because you're in different countries, and although you have such similar training, there are some nuances. So what I want you to really tell the listeners is what they should be looking for in a microsurgeon for breast reconstruction by giving us your background and training. So we will start across the pond in Sydney with Dr. Joe.
Sure, Terry. So I'm a fellow of the Royal Australasian College of Surgeons, which is our accrediting body in Australia for surgeons and specialists. And I also have a subspecialty interest in microsurgery. So I've trained overseas to achieve that status. And then I also specialize in breast reconstruction. It's the vast majority of the work that I do, more than 90% of the cases that I perform. So yeah, that I guess really is the credentials that I hold to do this work. And I recently became also accredited to do robotic assisted surgery. So that was something that I only took on roughly over a year ago now, and that was kind of maybe segues to the reason why we're talking today. But maybe I'll let Minas do a similar intro.
Thanks.
So similarly to Joe, board certification, that's our equivalent over here in the US. So to answer your question in terms of credentials in your surgeon, when you're choosing a surgeon as a patient, board certification matters in the relevant specialty. So beyond plastic surgery, I underwent further training in microsurgery. Actually, several things: burns, hand, micro. So I had a bit of an interesting kind of course before I ended up in microsurgical breast reconstruction, which, like Joe, is the core focus of my practice, and all the surgeons practice as a PRMA. There are 8 of us now. We all share the same passion, which is breast reconstruction, but with a specific focus on microsurgery. So as a patient, when you're looking for a surgeon, beyond certification and training, experience matters too, right? So the more you do in anything, the more proficient you become. So the search really begins with training, but then I think experience also matters a lot, because you can get trained in something, but if you hardly ever do it, then maybe your skills aren't what they could be compared to someone who does the same thing over and over every week. So and Joe and I actually connected over our shared passion and microsurgery, and I think you were actually to blame for that, right?
I'll take full
Terry?
credit. I'll take full credit for that.
I say blame, of course, tongue in cheek.
No,
we connected because of you.
Blame with great happiness on my part. I was really jazzed to be able to do that, because I think a lot of both of you in your work. So I'll take the blame.
Yeah, it's been
sure.
Absolutely. Sure. It's been fun. It's been fun getting to know you, mate. I mean, honestly, it's been I really enjoy our conversations, and I love the fact that we've connected. Really do.
Well, so here's what's interesting to me. This topic we're talking about today, I really hate to use this term, but I'm going to, because it's just fun in this space. We're going to take a deeper dive. But so this whole Proximie system that you were using, Dr. Joe, I'm going to let you guys unfold this story, because I'm trying to visualize in my mind how this all even happened. And you will explain it well to me. Well, yeah, I'm thinking, this is not like 2 mates calling each other up and saying, hey, let's play a few video games together. What did you do? Did you WhatsApp Dr. C? Did you text him? How did this go down? Well, this is a fascinating
I wasn't sure it was going to work, because it was the first time that I had I'd used the system. I mean, I had played with the interface. Our hospital was doing a demo with Proximie, and we have a lot of cancer specialists in my hospital, and so they're often doing live surgeries and stuff with conferences and so on. But it's always very clunky to do these kind of live surgeries, and people have to kind of travel across continents to come and sit in an auditorium, which is like a football field away from where the surgeries are taking place, and they're watching these surgeries on a screen.
Right.
This is how sort of surgical education is performed in that particular setting. And so I knew other surgeons were trying to move towards a more user-friendly way of doing this, and I heard about this Proximie system. But what really interested me was you can actually record everything from your operating theater. I didn't really think of it so much in terms of the live streaming capability. I just was interested to record the operation and be able to go back and review it for my own purposes.
Yeah.
And so the rep was like, "Oh no, well, you can actually live stream, to anyone who has an internet connection." And I was like, really? Like do they need to download anything? It's like, no, they just need an internet connection. And they need obviously to be invited. And so I just flicked Minas like I think it was like an email or a text. It was really like quite offhand. It was like in a day or two. It wasn't like a lot of warning. And I just said, hey, if at about sort of 5 p.m. your time, you happen to be finished your case, you might want to just click on this link, and I'll be doing a robotic assisted DIEP, which I had talked to him about, and it probably will time in my operation with that part of the op that I'll be doing that bit at that time. And he was like, oh, I'll see, maybe, who knows, kind of thing. Like, it wasn't like, a guarantee that he would be there. And so, I mean, I'll let him give his version of events, but essentially I was mid-operation, recording this operation. So I was doing a bit of narrating and stuff. And then all of a sudden, this guy's head just pops up on the screen. And it's like this kind of this voice is like, hey mate, how you going? Like, and then ensued a
Bingo.
really conversation while I was actually I think hadn't quite gone to the robot yet, so I was able to show kind of Minas how we put the ports in, and where the robotic access is, and then move across to the robotic console. So you actually, when you're doing the robotic operation, you actually leave the table and leave an assistant kind of standing with the patient, and you go and sit in a little console booth. But yeah, it was amazing because I could, through my earphones, and I could hear like Minas talking. I could just talk to him like he was in the room. That was pretty amazing.
Can I put in a shameless plug? So I actually did a YouTube video with you, Dr. Joe, on your robotic assisted DIEP. It's pretty amazing. So go over to the Deep Sea Foundation YouTube channel and watch him do his magic. So go ahead, Dr. C. I just have this, I wish I could have been a mouse in the corner, because I have this visual of that moment when there's the, hello, mate, how you going? You were probably so excited, Dr. C. I'm guessing you were as excited to make that hello, mate, as Dr. Joe was to receive that in his earbuds going, oh, it's him. He's here.
It was great. I was a little bit concerned, a couple of emails before the event, with the Proximie team. I think they were presuming I was, I don't know, maybe not technologically very savvy or something. And then, Joe chimed in because they wanted me to do all this stuff, and Joe chimed in and said, it's okay. He can work it out. It's fine. Just send him the bloody link, so. And it really was very simple, very seamless. It was a wonderful experience. I just clicked the link and, put my name in, whatever, to accept the invitation. And then I was in the OR with Joe. Yeah, we were just talking, and he could hear everything I said, and I could hear everything he said, and I could see everything he was doing. And the atmosphere in the operating room was, as I would expect. It was all very, very civilized and relaxed and peaceful and very pleasant and very zen. And Joe and I were just having a conversation while he was showing me what he was doing, and I could see everything in incredible detail. And it was really kind of surreal in many ways. It was wonderful experience, and definitely the way I think to go forward, instead of people getting on planes at immense expense and traveling to all these different places to watch experts operate and learn. A system like this, I think, is phenomenal, especially. And the live streaming is cool and everything, and it was cool for us because we could kind of chat and banter a little bit, but as Joe mentioned, the recording aspect of it really is where that's the gold, I think, because now you can just that cuts out all the time wasting too, because there's certain parts of procedures that people aren't that interested in, right?
Mm-hmm.
You've got to get to the important parts, the success defining portions of a surgery, right? You don't need to see people making an incision and dissecting down to where they need to be, and that's all very straightforward. So now with if you focus on the videoing aspect of it, you can come back and edit it and shorten the experience now, and so now you can really maximize education in that way. So that, as I said, the live streaming is cool, but the real benefit, as Joe mentioned, is I think in the videoing, and you could put libraries together of all these procedures. It could potentially be quite epic.
Well,
really good.
I think
I would add
of it.
one thing to that, if I may, Terry, which is just that I think when you're doing something innovative, because not a lot of people around it are doing this robotic technique, and it was important for me to have the ability to kind of show Minas exactly what I'm thinking as I'm doing it, because there are different ways you could be doing things at this particular juncture. It's not been defined, really what's the best way to approach things and what might be the risks and benefits, and we're still trying to extrapolate all that out. And I think as we get more experienced, you kind of become more sort of comfortable that it's working well and so on. But this is quite early on in my experience, and while I was being proctored, which is a kind of another way we train other surgeons, is to kind of have experts who sit in with us and help us to learn new techniques. There's no one to proctor me in this operation. I'm the only person, I think, doing it in Australia, and so therefore it's beholden upon me to try and get as many opinions from experts as I can. And so I really found that valuable. Minas, there's a bunch of questions I was asking you about, kind of the posterior sheath and, kind of these like additional smaller incisions for the ports and so on. And whether, what I think, from the abdominal morbidity point of view, those might all entail. But, the reality is that it's very minimal additional morbidity, but it's just having that capability to innovate in real time is pretty powerful.
Well, can you give us just kind of a 10,000-foot level, Dr. Joe, of the actual surgery that you were doing, so the listeners can kind of get an idea?
Yeah, so it was a Diep Flap, just like any other Diep Flap, in the sense that we were doing breast reconstruction using the tummy tissue. And where it kind of, I guess, diverted from normal was in many cases when we're trying to get the blood vessels out of the abdominal wall, we have to make an incision in the abdominal wall to retrieve that blood vessel. And I'm just like Minas, kind of fixated on trying to make that incision as small as possible and to do as minimal amount of damage to the abdominal wall as we can, so that after the operation the muscles work well and there's no problems like bulge or issues that might develop in the abdominal wall. So one of the things that sort of became apparent to me was that a lot of the blood vessel runs under the muscle in this space, because it's called this subrectus space, just between the abdominal cavity and the abdominal wall on the inside. And if you can look in from underneath and back up at the abdominal wall, you can then actually you can get that blood vessel from underneath. You don't have to kind of make the full incision opening on the outside. So the robotic instruments enable you to put the camera inside the abdominal cavity, look back up at the abdominal wall, dissect those blood vessels free, and then pull them out through a tiny little hole. And it's kind of like a magic trick when you kind of see it. I think the videos that I shared with you kind of show, retrieving to 20 centimeters of blood vessel through a 2 or 3 centimeter incision. It's great.
I know.
To be able to do that.
It was mind blowing to see that. Yeah, that is in the video.
Yeah, it's great, and it really means that the fascial incision and the muscle incision, which I think is even more important, is very limited. And I think that's but it's not for everyone. I think I mentioned in that talk, I think it depends upon the anatomy of how that blood vessel travels through the muscle. Sometimes it just goes like straight through, like over a centimeter, and other times it meanders through the muscle over a long distance. And so I don't think every person is a candidate for robotic assisted, but for those that are, and particularly if you're doing a bilateral where you might have to interfere with the muscles on both sides, I think it has. But yeah, we're still trying to collect data prospectively and demonstrate, what the outcomes are like for patients in terms of their post-operative pain requirements and their ability to kind of use their abdominal muscles sort of shortly after the surgery. But yeah, it's been encouraging, the early results for sure.
Yeah. So one thing I do want to mention, what I think was cool for you, Dr. C, and if you're comfortable talking about this, you know, I know that you're not doing robotic surgery right now. There's a few reasons for that, but yet you were able to learn via Joe's experience. But there's a reason, because I remember Dr. Joe telling me that his hospital facility has, you know, they have this system that they're using. What is it called?
It's called the Da Vinci, and we actually
Yeah, the
have
Da
2
Vinci.
robots.
I need more
Very
coffee this
full.
morning. So I guess what I'm asking you, Dr. C, or maybe asking you to comment on, is the fact this isn't available everywhere in the US. Do you feel comfortable talking about that?
Yeah, for sure. I mean, the main issue we have right now, our main barrier to entry, as it were, is certification or proctorship.
Mm-hmm.
So, and it's interesting. Our facility actually has multiple robots.
Mm-hmm.
That's the irony. We're a very large robotic center. I think actually our hospital is one of the largest robotic centers. When you look at the number of robotic cases being done, surgeries being done, it's one of the highest volume centers in the US. And so I'm currently in the process of moving to a different campus, a new hospital. And 2 of the robots will be going with us. So we're going to have access, but ironically, it's been problematic for us getting the sign off to allow us to actually start doing it. So it's a bit, for us, it's more logistics to overcome, a little bit of politics, but we're going to get there, right? So I think it's really important to include robotics and robotic assistance in our armamentarium. I couldn't agree more with Joe that it's not going to be for absolutely everyone. You know, when you've got a cool new toy, you want to use it for everyone, right? So, but realistically, you're not going to need to use it for everyone to improve outcomes. Some people aren't going to be good candidates, and others you just won't need to use it. But there are going to be certain situations where it's going to be really very beneficial. We have ways of minimizing the hit that the belly takes, the abdominal wall, as Joe was mentioning. When you do deep flap surgery, when you perform the surgery, everyone focuses on preserving the muscle. And Joe and I have talked about this at length, you know, but that's only half the equation, really, because you also have to minimize injury and preserve the nerves that power the muscles. Otherwise, saving the muscle is really kind of, you know, you're kidding yourself if you think that just saving the muscle is everything, right? So if you look at someone who has a spinal cord injury, for example, and who's now wheelchair bound because of their spinal cord injury, because the muscles in their legs no longer have the nerve supply, that the nerves are still intact, but the nerves aren't powering the muscle anymore because there aren't any impulses going through the nerves because of the spinal cord injury, right? And so what happens is when the muscle stops being powered, it wastes away. So if anyone knows a friend or a relative or someone who's had that type of injury, they have total wasting, severe, very, very severe wasting of their leg muscles, right? So imagine the same thing in the belly. If you're preserving all the muscle, but you're cutting the nerves, then potentially the muscle can significantly waste away and you can still get the bulging that Joe mentioned. And so when you minimize the incision you need, but at the same time, you can still see everything perfectly, then that decreases the chances of injury. The issue we have currently with patients as we're trying to use the traditional non-robotic approaches, and when we're trying to use shorter incisions in the fascia, which is the strength layer on top of the muscle, we use retractors, lighted retractors. You're kind of yanking on tissues a little bit more, even if you don't mean to, and you can get traction injuries or pulling injuries. Things get stretched, so now you don't need to see the nerves specifically, but you can still stretch them and damage them. Now, usually with deep flap surgery, there seem to be two camps in terms of surgeons. Some of us, like Joe and I, are very, very, almost obsessed with preserving nerves and minimizing nerve injury. And if we have to cut a nerve for whatever reason and we can repair it, we do, because we're microsurgeons and it's easy. And why wouldn't you? The problem is, or the issue is, that the surgeons that don't preserve the nerves or don't obsess about them usually get away with it because the anatomy in the abdomen is such that in most people, even if you cut a nerve or two, the other nerves that are intact kind of compensate and the muscle does fine and the patient doesn't develop a problem. The problem is if you don't have that patient and their anatomy, they have the anatomy where they have far fewer nerves, but the nerves that they do have are much more important and major because they only have a couple of main nerves. If you cut one or two of those, then you're going to get a bulge. Right. And you really can't predict that easily who's got which anatomy, right? So the best approach is just to be very cognizant of the nerves and really think about them. And that's actually where Joe and I connected initially, was a lot over that stuff, I think.
Right. Well, so what I'm going to do too, this is reminding me, Dr. C, that we also did, there's another YouTube video that you and I did on, optimizing the abdominal wall. I'll put that in the show notes as well, along with Dr. Joe's YouTube on his robotic assisted deep. So yeah, go ahead, Dr. Joe. Fascinating.
No, I totally agree that that's obsession with nerves. I guess I initially was reaching out to Minas through you, Gary, about the sensory nerves, because I was not really that impressed with the outcomes as far as breast sensation was going, because I think that was something that I thought could be done better. And then I was obviously hearing patients kind of saying to me, we're aware that this is being done overseas, and so I really reached out to find out more about that. But I think in my own mind, I kind of obsess about the motor nerves just as much, and I'm even starting to obsess about the sensory nerves in the abdomen. Minas, I haven't talked to you about this yet.
Okay, I want to hear this. Did you ever have a conversation? Obsessed with me? I want to hear this, Dr. Joe.
Yeah, that's something that just patients kept saying to me, and because since we've been doing Semmes-Weinstein filament testing, I keep noticing this area, between the belly button and the pubic hair that's totally numb. And even like a year down the track, I'm like, I would have expected to come back, but this area, gets smaller and smaller. But there's kind of that bit of the belly that you lean against the bench, is kind of touching is numb. Yes. And I was like, we should be doing better at that. So yeah, I've started to come up with a strategy for that, using some of the sensory nerves in the flap, and rejoining those to the sensory nerves in the abdominal wall. So I'll keep you posted.
Yeah, please do. Yeah,
but I can't see how it's gonna hurt. But yeah, it's just it's another little. I mean, you're dissecting those nerves anyway, right? And you're choosing which one you're going to use for your coaptation in the breast. But I just trade off, use one for the abdominal wall to abdominal flap. But even that's the kind of technique that could affect kind of all abdominoplasties.
So I'm going to segue, Dr. Joe, because you mentioned that you wanted to talk about the Sia vessel.
Yeah, it's an interesting thing, because I reckon that, and I mentioned this to Minas before, it's sort of in our literature, it's kind of a bit sort of talked down as an option. A lot of surgeons sort of tried it for a while, had a bad outcome, now don't use it at all. And I think that's crazy, because anatomy is so variable, that you can have a patient that has huge SIA vessels, sometimes equivalent to the DIA vessels, and they may only have a need for a small breast. They may only need like an A or a B cup breast to feel whole. So, how much artery do you need to supply a small volume, 100, 200 grams of tissue? And so there are certain circumstances when I think that operation is wonderful, because you don't need a robot, you don't need anything, you don't need to make any muscle incision at all, because the blood vessel travels on the outside of the abdominal wall.
Okay.
And so, I guess I've been trying to create my own algorithm in my mind as to like, what's the best case scenario anatomically? Like, is it someone whose blood vessel runs superficial? Is it one who comes straight through the muscle in terms of a short intramuscular course for the DIA vessel? And so I have kind of been doing this throughout my whole practice, sort of juggling these different options and putting them in different ranks. So when I'm looking at, I have the privilege of getting CT scans of all my patients, so I can go through this thought exercise every time I do the case and kind of plan how I'm going to get these blood vessels out. And I know that in the States, that's not something that's done as routinely, just because of access issues and so on and cost. But yeah, where I'm from, we can get that every time. And so it's become obvious to me that there's a certain set of steps that I use to get to test whether an SIA flap's going to work.
Mm-hmm.
And I wanted to bring it up because I know that some people go, well, I'm not a candidate for a robotic assisted. That must mean I've got a worse anatomy. But actually, it's not the case. If you may have a better set of anatomy. That means it's not even needed. And so we've been doing some quite large flaps with SIEAs without seeing any complications. And the main complication that in the literature people talk about is fat necrosis, where the blood vessel isn't big enough to really supply all of the breast. The fat that's come from the tummy, in some section might not get enough oxygen because the blood vessel that was feeding it wasn't big enough.
Mm-hmm.
And that could happen with Diep Flap as well if you don't choose the right perforator. But I guess it was just a topic to bring up, because I know Minas likes to use it as well when it's appropriate. And I think it's just somehow we've all got to get together and decide on what factors makes it appropriate, as opposed to just in your hands and in my hands.
Well, this is something I distinctly remember, Dr. C, when my husband and I were sitting in consult with you, is you talking about that, and you drew it out on a piece of paper. And you said, I remember, not everything I remember about my consult, but for some reason that I remember that, and you saying, we're going to look for this first. So can you give the listeners a bit of an anatomical description of, Dr. Joe touched on it, but can you give the listeners a bit of an anatomical description of that, where it's located versus the deep vessel?
Yeah, sure.
Because I do remember this in my consult, oddly enough.
Yeah. I mean, it fits perfectly into the dissection for the deep flap anyway, right? So the steps that you take to outline your deep flap, and the initial parts of the deep flap surgery, the dissection and preparing the tissue, the lower incision, which is in the kind of crosses the groin area, or just above the groin area, that's where this SI vessels, that's where they live. And so they come up from the groin, but they, instead of traveling through the muscle, they travel on top of the musculature and the sheath and within the fat, and they supply the fatty layer under the skin directly without perforating through the muscle, right? So the DIEP flap is a perforator flap, so deep inferior epigastric perforator flap. That's because the muscle, these blood vessels perforate the muscle as they travel upwards into the fat. The SIA blood vessel, that artery doesn't enter the muscle at all. It just stays on top of the abdominal wall, which is, when we say abdominal wall, we mean the strength layer on top of the muscle, which is the fascia, which, as I mentioned earlier, we're trying to minimize that incision, because that's what really is the strength layer on top of the muscle. So if you don't even have to make an incision in that layer, that's already a massive benefit.
So
And
this would be
these
the fascia, and then the SIEA is on top of that versus the deep.
is on top.
Yeah.
Exactly. So the deep is deep to the fascia, runs in the muscle. The SIA flap, the blood vessels run on top. So the dissection is just a tiny bit more than you would perform for a tummy tuck. For a tummy tuck, you don't look for these vessels other than to clip them and make sure they don't bleed. But with the SIA flap, you dissect a little bit further into the groin to get as much length as possible for these blood vessels. And then, it's not just, as Joe mentioned, not everyone has the appropriate anatomy. And by appropriate anatomy, we mean, number one, you have to have them. Number two, the blood vessels, they're not just present, but they have to be large enough. Now, sometimes you're not sure if they're large enough until you dissect a little bit more. So if they're present, we do a little bit more dissection and explore. And then the other thing that matters is the tissue that these blood vessels supply. So the branching pattern. So when we do get CT scans, it's not just whether you have the blood vessels or not. And this applies to any flap. What you really need to also evaluate, you got to see how these blood vessels branch out into the tissues, right? So the branching pattern is really important. Even if you're not a candidate to have an SIA flap on its own, sometimes you actually need to add that to the deep flap to get the maximum amount of tissue. Sometimes that superficial vessel kind of supplies more of the outer part of the belly, and the deep system supplies more of the central part of the belly. Sometimes blood flows in through the deep system and comes out through the superficial system. So sometimes you have to add at least a vein. I mean, so it really is an algorithmic approach. It's not either or. That's kind of simplistic. So patients need to understand that sometimes you're going to get more than one set of plumbing to make something work. Yeah. Right. And so the CT scan shows the presence of blood vessels, but it doesn't show the flow. Now, how much blood goes through those blood vessels? It stands to reason, and we know that the bigger the blood vessel, the more likely it is that the flow is good enough. But the branching pattern also matters, right? So it's definitely an algorithmic approach to things,
Yes, and I think it's all about, in very simple terms, it's all about the plumbing and the diameter of those vessels, the strength of them, and how you guys so creatively, look for these when you're in surgery, and the ability to optimize the blood flow to the flap, like you said, Dr. Joe, to minimize fat necrosis and all of that. So, yeah.
Yeah, I use a lot of tools to try and work these things out. So obviously the CT is one way. We also use the audible Doppler, which is this old school technology, but it creates this great degree of experience, because you can listen, without making an incision, you can listen to these blood vessels, and you can get a sense, just having listened to hundreds and hundreds and hundreds of blood vessels, what the kind of flow is like in that blood vessel. And that's one bit of data that you add to your equation. And then you kind of go in and have a look at the blood vessel. You can see how it pulses and how big it looks. Does it look big enough to me to supply this much tissue? That's only, I only get experience doing that by doing these cases. And obviously Minas has done thousands more than me, I think, in terms of, or at least with his whole group. I think you're 11,000 at last milestone, Minas, or something ridiculous like that. Or 11,500.
I think it's 11.5. Yeah, last count was, I don't know. Yeah, we count in 500, so we passed 11.5. I think we're knocking on 12 now.
Cool.
But yeah,
and
there are 8 of us. It's easy to do when there are 8 of us, right? There's only one of you, right? So,
but still, I'm just getting at the point, like this is the kind of, these things are all, you know, experience based, and so that's where like you kind of, you know, I probably use more data points because I'm wanting to kind of get it right because I'm not doing as many cases. But I think that's the key, is you're using as much information as you can get about these things to get it right. Because the other thing we do is we will isolate the flap on different systems and clamp off the deep system temporarily, see what the superficial system actually does in reality, what it's supplying, and then vice versa. We can flip that and clamp and temporarily clamp the superficials and see what the deep does when it's on its own. And those kind of, yeah, I guess is go into the algorithm and kind of say, well, yes or no, am I going to use the superficials? And you've got to kind of do that in a timely way that doesn't take up the whole day. You know, you've got to kind of make a decision at some point. But there is, yeah, I'm routinely trying to do a superficial where I can. So I think it gives the best outcome for the patient's abdominal wall, essentially. But yeah, without kind of, yeah, without risking the breast, which is the primary goal, is to make sure the breast is healthy and it's got a full blood supply.
Yeah, I feel
And
like
Terry,
you guys...
you and I have also, sorry, I was going to mention also the SPY, which I'm sure patients have heard of now. You know, it's an intraoperative tool that we use, you know, so after we clamp off blood vessels temporarily with little temporary clamps, you can test the blood flow and actually see where the blood is going, rather than just a visual exam from the surgeon. You actually get the blood flow kind of image, the perfusion, using this tool. It's intraoperative angiography, basically, but most people know it as a SPY. So, and we use the same techniques with, you know, the same kind of algorithmic approach with things like the apex flap. That's another technique that probably patients have heard of, you know, apex flap. You know, we have patients that, you know, when they're looking around or considering traveling's obviously a big deal, but I get asked that fairly routinely. You know, I want an apex flap. Well, it's like, okay, well, an apex flap is great if you need it, but you know, not everyone needs an apex flap, right? So why would you do an apex flap if all you need is one perforator and you're done? You know, why? So you want to choose a surgical team that is able to perform whatever you need to maximize your outcome and get the best results. But that also means that you don't want to be doing things you don't need just because you can, right? So
that's the education of the patient.
Yeah,
they hear a
techniques,
term and think they need it. That you actually drew some photos of that in that YouTube. You penciled in the apex. Yes, I know you don't remember. I do. It's going to be in the show notes.
I think I've seen that one too.
But the apex, yeah, it's a brilliant technique, and the techniques that Joe mentioned in terms of temporarily clamping and then, you know, using the SPY, and even if you're not doing an SIA flap, even deciding whether you need one or two perforators. If there's a lot of muscle between the two, you don't just want to cut the muscle. But then if you need the extra perforator, that's where the apex flap is what you need, right? So anyway, it's fun talking about all these different things. And when people ask, you know, they ask me, well, actually a lot of surgeons, you know, they'll say, yeah, don't you get bored doing the same stuff every day? It's like, well, even deep flaps, I could do 6 deep flaps a week, and potentially they all have a different algorithm. You know, I have to do different things to get them to the same outcome, right? Which is the successful breast reconstruction and the most aesthetic result possible of the breast and abdomen, right? So getting there often looks very different intraoperatively in terms of the steps you need to make and take. So that's what keeps you going, really.
Yeah, and I mean, circling back to this, I just feel like you guys have to get creative each time you know, operate on a patient. And going back to this Proximie system, Dr. Joe, what if we were going to just kind of wrap it up, what is was or is your favorite part about this and involving Dr. C in this? What's the highlight for you? And also, letting listeners, whether they're patients or other surgeons, I hope will be listening to this, encouraging them, to get jazzed about this. I was, obviously.
Yeah, well, I mean, it's interesting because we first met Minas and I during COVID, right? And there was no possible chance I could get on a plane and come over and see his technique. And so it was really like, we had to kind of get digital and kind of share notes. And I think he sent some textbook chapters he was working on and information for me to learn from. But then this really opens up the door. And I guess what I'm really excited about is when Minas gets Proximie in his operating theater, and then I can come in and I keep putting pressure on for the reciprocation, because that's my my hidden motive, is to kind of get in and see behind the curtain, because that's, I think, those kind of moments when you learn a lot, is when you see someone in their element kind of making those decisions in real time, because it's not the kind of thing you can ever get from a textbook.
Did he get bossy at all through the ear tubes? I mean, did he I'm just asking.
He may. There is a like a functionality where you can annotate the screen, and so at that point in time, I wasn't really rocking much facial hair, and he may or may not have kind of suggested a haircut or suggested a mustache or that nature.
Dr. Okay, we'll bring it down here a minute, because I'm going to get back to something else. What just jazzed you about Proximie and being with Dr. Joe?
Yeah, it was really that. Yeah. No, I think go Dr. C. Let's see what you got to say about this.
Yeah,
we think we want to
honestly, know. It was just being able to connect. It's like two guys, no agenda. Same passion. Just when you're passionate about stuff and you meet someone who shares your passion, you don't even know what you're going to learn, but stuff just comes out. So and that's how you learn, right? Because it doesn't matter how long you've been doing it. If someone else is just as passionate as you and they're super smart, like Joe, chances are they can teach you something too. It doesn't matter how much experience you have. So it's just a lot of fun, and being able to talk to someone who does have the same goals, and who is a massive patient advocate, and who wants to keep pushing the specialty forward and share knowledge. I mean, it's just fun. This is what it's about, And so it's just refreshing. It was a lot of fun for me. My only regret about that day was I couldn't hang out for the whole time because of the time difference. I had to put the little one to bed, so I had to kind of log off. But yeah, it was a great experience, and the platform is fantastic.
Well, and can I just say, because here we all are on our background screens. Speaking of coordinating efforts, so can I just tell him, Dr. Joe, you're sitting in your car so you don't wake your family up. It's midnight in Sydney and pretty early morning for me here in Seattle, and there's Dr. C in Texas. But I don't know if you guys are comfortable answering this question at all, but I'm going to go back to, music. So, we've got AC/DC in one corner. We've got, what is it? Optic Monkeys? What?
Arctic Monkeys.
I don't
Arctic
know.
Monkeys.
I don't listen to that. I don't know who that is. Who chose the music? Just saying.
It was already. We actually started talking about. Didn't we start talking about single malts and bourbons and things with?
Yeah. So another interesting thing that happened during that call was the surgeon I work with, Dr. Cindy Mack, happened to just
Yeah.
walk into the
Yeah,
opera
that's right,
theater.
Cindy.
So,
Yeah,
yeah,
she's
yeah, yeah.
lovely.
And
She's
she's a
lovely.
massive
She's
whiskey
great.
fan. And
Yeah.
Minas asked me, said, how do you manage to get on with your breast surgeon so well? That's not such an easy task. You know, internationally, there's a bit of friction. And I said, well, it's easy. You just buy them whiskey. And so that started a bit of a conversation because she's a bit of an aficionado. But no, it was and she was able to see kind of how the program was working so smoothly, and she started really using Proximie quite a bit now.
Mm.
So it's yeah, we're on a bit of a mission to get a good camera to film the kind of up close stuff that when you don't have the microscope or the robot in there, because that's a challenge to to get like a loops camera is my next purchase.
Mm.
Because you'd like to be able to show like the perforated section and stuff like that. But yeah, no, she's on to that as well, and I think that she did. It took a fraction of a minute to work out kind of how good this was just from seeing kind of Minas and I interacting. She was like, what's going on here? How do I get involved in this? This looks really great.
Well, I mean, I can't think of two better people cross-continental to be using this Proximie system and to encourage others to learn from it. I just, you two would be the stars in my book. So yeah.
But to the democratization question, because that's a really
Yes.
important one.
Yeah. Let's go back to that.
I think there is a lot of opportunity there, particularly for like what Minas was saying, surgeons getting on planes,
Mhm.
traveling halfway around the world. Like I have a lot of visitors come from India and places like that where it's a huge impost to come, and they can only spend brief amount of time seeing some of these techniques, and they've got obviously to go back to their countries where they've got a huge burden of people needing surgery. And I think this kind of platform makes that just so much more accessible for people from developing world, from regional centers, for example, from just about anywhere, really, anywhere with an internet connection. So it does really break down a lot of those barriers to being able to access these things. And I think that the guys running Proximie have that in mind, as an outcome they want to pursue, which I think is great.
Yeah. Well, if you guys will indulge me, I'm going to end with another quote today. I love quotes. So, like the two of you, this is an innovator. This is from Henry Ford. And he says, anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning is young. So, thanks for joining me today. And what do you guys say that we just follow that lead from Henry Ford, and we'll just stay young and keep learning together?
Love it.
Sounds like a plan.
Yeah. Hey, thank you both for joining me today. I really appreciate it. Dr. Joe in Sydney, Australia, Dr. Joe Dusseldorp, who's a microsurgeon over in Sydney, Australia, and Dr. C in San Antonio, Texas. Thanks so much, guys, for joining me today. And I guess it's lights out for Dr. Joe.
Yeah, that's it. I've been still too long. My garage sensors has switched off. But have a good night. Have a good day, everyone. I'm off to bed, and I'll speak to you soon.
All right. Thank you guys so much.